If you have ever wondered what it is like to operate on a beating heart, having a human's life in your hands, then you're going to want to stay tuned. Hi, I'm Michelle. I'm a practicing PA, not in cardiothoracic surgery, but this is my channel, The Medicine Couch. And on this channel, I try to give you an inside look into what it's like to work as a PA or an NP in all of the different various medical specialties. I'm honored today to speak with Janna Harris. She is a PA who has worked in cardiothoracic surgery for many years. She's also president of the APA CVS, and she's going to share what it's like to work in cardiothoracic surgery, the good, the bad, the long hours, the call, and all the reward that comes with it. What is it like when you're operating on a live human heart? Like, do you have all of these emotions? Or does it really kind of give you some philosophical thoughts? Or is that not really how it works in cardiothoracic surgery?
So anytime you're actually in surgery, I call it left brain, right brain. Your left hand's doing something, your right hand's doing something, your brain is thinking 3 steps ahead. So there's not time to be emotional. There is just like sometimes you can say, okay, this part's going wrong. I have to pay even more attention, but you can't get emotionally involved. You have to stay very, very focused during the surgery. I would say it's more the after. Like if I remember one case very particular, it was a type A dissection. We're literally doing CPR in the operating room, get the case going. And it wasn't until the next day or two when you see the person awake in the ICU with family members around, you're like, oh crap, like we literally saved this guy's life. And that's where like it starts to sink in and you're like, oh, this is what we did.
I guess that makes sense because, in medicine, like you said, you have to be focused on what you're doing and you're almost, I don't want to say mechanical at that point, but you're doing a procedure and that's what you're focused on, not so much that it's a human being in front of you. You guys do all kinds of surgeries, I assume, in cardiothoracic surgery. Will you tell us kind of what the more common surgeries are that you do?
A lot of it depends on what kind of facility you're in. Small facilities are going to do more of your bread and butter, what we call. So more of your cabbages, more of your valve work. The more you get to like an academic center or even a center that has good support with ICU and floor, that's where you're going to get like your big aortic work, where you can do like elephant trunks or like your transplants, your VADs, your ECMOs. So it depends on what setting you're in.
Right. And for somebody watching this who doesn't know, maybe, pre-PA or pre-NP, tell us what a cabbage and an elephant trunk are.
So cabbage is coronary artery bypass graft surgery. Instead of saying that whole big thing, we just say cabbage, CABG. And we'll say like cabbage times 3. That means we did 3 bypasses. If we say cabbage times 4, we did 4 bypasses. Elephant trunk is a different beast on itself. You have your aorta come up, you have all your great vessels coming up off of that. And elephant trunk is basically replacing not just the aorta, the ascending aorta, but you're also going into these other major branches, and that's what you're working on.
What do you think is the most complicated surgery or most involved, intense surgery that you've ever been in on?
Probably the most intense, if you're talking intense, when I think of intense, I think of it as life. I'm not thinking of it intense as in complicated. I'm like right. And so
life or death,
for me, those, So for me, those are going to be like your type A dissections where it's not going well. Those are going to be your intense moments. It's an acute thing. You have a lot of inflammation. The tissue is angry. It doesn't want to be touched. And that's exactly what you're doing. So you can have a lot of complications from that. But my favorite surgery actually is aorta bifem, where you're more in the belly and you're replacing the part of the descending going into both femoral arteries down the leg. So it's a big surgery you're doing. It's an all-day surgery, but for some reason that is just my absolute favorite surgery.
Yeah. And so when you talk about these surgeries, you're in there being first assist in the operating room, correct? Yeah.
Correct.
So what kind of things do PAs and NPs actually get to do? Are you mostly like holding retractors and throwing in maybe some suture, or what all do you get to do?
So again, that is dependent on where you're at. If you're at an academic institution, you're going to have lots of fellows and residents that are there with you. So you could be first assisting. You could also be second assisting, where the fellow is doing more things. But as a second assistant, you might think that, okay, I'm just like sucking or blowing or things like that. But you're important in the role in that you're actually teaching the fellow and the resident. The surgeon's teaching them how to do the surgery. You're teaching them how to assist and what to look for and what's coming next, what you need to think about. And that's where your role comes in. If you don't have residents and fellows, your main job is going to be first assisting. You're going to be there with the surgeon. The longer you're with a surgeon, the more you have a rapport with them, the more you get to do. And again, that depends on where you are, what's happening. I remember one transplant, I was the one who was sewing part of the heart back together. And that's just where you have the comfort level with your surgeon and what they're comfortable with your skills and you work together.
Are there both PAs and NPs in the operating room, or in cardiothoracic surgery, are you seeing more of one profession than the other?
Yes, there are both involved. It tends to be PAs more in the operating room, NPs more out in the hospital or the office.
And I assume that's mostly just because their training doesn't normally incorporate operating room as ours. We have surgery rotations. Do they mostly have to get their RN first assist, RNFA, I think it's called?
A lot of hospitals lately have been requiring NPs to go get their RNFA.
Yeah. And so as we're talking about other places that you can work in cardiothoracic surgery outside of the operating room, can you talk about that a little bit? Like, are there PAs and NPs working in cardiothoracic surgery that are only working maybe even in an outpatient clinic where they're seeing follow-up, or does everything happen in the hospital?
So you have both. You have inpatient and outpatient. Again, cardiac surgery is not a very consistent thing across the nation. Yeah. It splits so many ways. You'll have like smaller centers where the PA will do absolutely everything. They'll be in the OR, they'll cover the ICU, they'll cover the floor, they'll cover night call and get patient calls from home. They'll get, nursing calls from the floor. All the way from that side, and on the other side of the gamut, you can have one team that covers the ICU, one team that covers the inpatient side, one team that covers OR, and one team that covers the outpatient. So there's no consistency across the nation. It just depends on the setup of your hospital.
Good to know if you're interested in this specialty that there is lots of variety. You just have to be careful when you're interviewing, right? To really understand what that particular position is offering.
Yeah. And there's nothing wrong with asking those questions during an interview. Right. Like, you want to have a good setup for you. They want to have a good setup that you feel comfortable in and that you're happy and you're going to stay. So those are the questions you need to ask during an interview. You need to be like, okay, what exactly is my role? What are other people's roles? Do they cross cover if they're short staffing or something?
Yeah, good point, because people have to remember that we're interviewing them as much as they're interviewing us. And it has to be a right fit for both parties for it to be a long-term relationship, just like in dating, right?
Yes. So yes.
When you were in PA school, was cardiothoracic surgery what you wanted to do? Like, did you know that in PA school?
Studying through school, the heart was the thing that I was most interested in. People were like, wait, this chamber, how does this go? And I was like, oh, it's ba-ba-da-ba-da-ba-da-ba-da. It was just so easy for me. Luckily, I was able to do a cardiac surgery rotation. And you can ask my husband this. He will say every single rotation, and cardiac surgery was like one of my last ones. He's like, every rotation you came home and you're like, I hate this, I hate this, I hate this, I hate this. And he goes, but when you got to cardiac surgery, he goes, you did not stop talking about it. And I was like, oh, okay, well, I fit right where I was supposed to be.
Yeah. So can you kind of walk us through, I don't say a normal day, there's no normal day in medicine, but just in general, like if you had to give somebody an idea of what your schedule is like on an average day, can you kind of walk us through?
Usually you start off your day with finding out which patients you're taking care of, reviewing all of their labs or x-rays, going and seeing the patient, doing your physical exam on the patient, and doing whatever you need to do for that patient. So if you need to increase blood pressure, decrease blood pressure, add diuretics, everything that you're doing to prep them toward discharge and to get them out of their very acute stage. If you go into the operating room, you're looking over your cath films, you're looking over the patient history, making sure, maybe the surgeon had somebody else post it for a cabbage, and you're looking through and you're like, oh, but they also have AFib. Are we doing an appendage ligation? And you want to make sure that that's part of the surgical plan or ask the surgeon why it's not. So either way, you start your day prepping whatever pathway you're going before you go to the operating room. And then you come out and you're like, okay, where do I leave off? I had to pick up. Do I have consults I have to do? Your typical day starts at a very specific time. Your end time, you cannot predict. That's one of the things about this job. There is no predictable schedule as to when you're done your day. One of the bad things is you can't say, yes, I'm going to go to dinner. I'm going to meet my friends at 5:00. And you're calling all the time saying, I'm still in the operating room. So sorry, canceling again. It's the hard part about this job. You learn how to adjust your schedule and be like, okay, I'm not working this day. So this is when I'm going to meet up with friends.
And how long do these surgeries typically last? Or maybe it's easier to say, how many surgeries do you normally do a day?
So you're going to normally do 1 to 2 surgeries a day. They're going to pretty much take one surgery is going to be the first half of your day. Second surgery is going to be the second half of the day if you're doing a second case. Your average time from coming into the operating room, prepping lines and all that stuff to moving out of the room, you're going to be there for at least 4 or 5 hours.
If I'm not mistaken, a lot of times PAs and NPs, their job is to harvest the saphenous veins for the bypasses. Is that correct? Can you talk about that a little bit?
Correct. Yeah. So what we call endoscopic vein harvesting. We also do endoscopic radial harvesting. Those are the conduits that we use for your heart bypass. And the PA or NP's job is to get the vein or the artery out of the arm, vein out of the leg, artery out of the arm that we use. It's an important step. A lot of people think, okay, I just got to get it and get it out. If you damage it, if you cause holes in it, the longevity of that conduit goes down. So it's a very important part of the surgery. You need to be able to get it out in a timely manner because the surgery needs to go on. You don't want the patient sitting there under anesthesia longer than they need to be, but you have to have a really good quality vein or artery because this patient's life and their heart depend on it.
That's something that the PA/NP is pretty much doing on their own, right? Like, is a surgeon up in the chest doing something else and you're doing that exclusively?
Correct. You're down at the leg taking vein while the surgeon is opening the chest. So you're performing your procedures or your surgeries at the same exact time.
Have you ever worked in, I think you said something about transplant earlier, like do you guys do heart transplants or is that like a very specialized part of cardiothoracic surgery?
It's a very specialized part because not every hospital does them. You have to have a transplant center or a big heart failure center. So again, it just depends on where you are and where you're working.
I had interviewed a PA who works in cardiothoracic surgery, but he worked with a transplant team for a long time, and then he became their organ harvester. So basically, he goes by himself. There's not an MD with him, and he goes to different hospitals where they have a donor, and he's the lead surgeon, I should say, in harvesting the heart. And I'll put a link to that video up there because it's really cool. I think he's only one of like 2 PAs in the whole country who do that.
I watched that interview, so I found that very interesting. And it just reminded me of, PAs are capable of doing so many things. Like there are some centers where PAs are opening the chest, PAs are harvesting the mammaries, PAs are doing the groin cannulation if you're not doing central cannulation, you're doing groin cannulation. PAs are capable of doing all these things. There's nothing wrong with it if you're getting trained and you're able to do it safely, and it just helps the whole process. It helps the surgeon, helps them focus on other things if you're able to assist that way.
But again, for anyone who's watching, these are very well seasoned PAs who have lots of training. We're not out there trying to be renegade PA, like we can do everything. It's with training.
You have to walk before you're running,
right. So I wonder, are there any procedures outside of the OR that cardiothoracic PAs or NPs would be doing?
Your main ones are going to be your chest tube removals, chest tube insertions in some places, your pacing wire removal, wound vac changes, I&D on the floor. Those are all things in your typical day that you will be doing. And the interesting thing, if you're doing ICU specifically, like they'll put in swans, they will put in arterial lines, central lines, tunneled catheters. There's a lot of procedures that ICU specifically will do that you're kind of cardiac surgery PA might not do if they're just floor or OR.
So let's talk about money, because money, everyone wants to know about money. And in some of my research and videos I've done before, cardiothoracic surgery normally ranks up there as one of the highest, if not the highest paid specialty. These are just things I'm seeing off of reports. Do you feel that that's actually what's happening out in the field? I mean, is this one of the highest paid specialties out there?
It is. Cardiac surgery is definitely one of the highest.
Give us an idea, like a range of salary, what you would expect somebody who has some years of experience as a PA, and they're looking for a position. What would be a normal range that you would think a cardiothoracic surgery PA or NP would be bringing in?
So when you look at the reports that are out there, yes, cardiac surgery is in the top. It will probably always be in the top. The problem is things are a little skewed with locums, because locums is such a big industry, and locums are definitely going to get paid more than your staff cardiac PA. I would say your probably average cardiac PA starting point is going to be somewhere between, again, a lot of this depends if you're taking call in the operating room. So if you're talking the whole range of cardiac PA, you could be anywhere from 100,000 all the way up to about 120, 130 as a starting. If you got experience, you're going to be up there about 170, 180. And then it's just going to go up from there. And the more you get into locums, you're going to be up around 200 or more.
There must be a fair need for locums in cardiothoracic surgery, because I see it a lot.
It is a huge business that has been growing. I think what happened was you had a lot of the older generation of cardiac surgery PAs retiring. New PAs coming in are not lasting as long. They're not staying in cardiac surgery for their whole career. So they're kind of coming and going. So you have this finite amount of trained PAs left. And so you have a lot of facilities that are like, we have job vacancies, we can't attract them. A lot of it also is the job is just so demanding and so stressful, and you have hospital administration on top of it, and other things on top of it that you're just like, I just want to show up and do my job.
I can see the appeal, especially the amount of money that they're able to make can afford them the opportunity, if they want to, kind of relax for a month or so in between positions. Yes. and kind of recharge a little bit, which isn't necessarily a bad thing. I mean, there's pros and cons about everything. I think the cons would be not having that rapport with your surgeon like you would if you worked a long-term position.
Yeah. And it's not only that, it's you have to be able to travel. You have to be able to be away from home 3, 6, 12 months at a time.
So are there certain personalities that you think are very well suited to cardiothoracic surgery, or personality traits that help people really excel in this field?
Yes, for sure. One, you have to, I don't even know if I'm going to say the right words for this. You have to be able to compartmentalize. You have to be able to have it be in a tense situation, have somebody standing a foot away from you saying all kinds of things, but you can't think about that. You have to stay focused on what you're doing in the OR. They're not saying it personally. You have to just let it go. They're just saying things because it's a very tense situation. And if we don't get out of it, there's going to be a bad outcome. So you have to be able to just let things go. This is a field that is a high stress field. You have to be able to be very good at multitasking. You might get calls from patients on the floor while you're in the operating room. You have to be able to answer those calls. You have to be able to just constantly think about what's going on more than just the one thing you're in. I don't want to say you have to be a strong personality, because you can be too strong, but you do have to be able to stand on your own, especially if you're in the operating room.
Yeah, because surgeons are kind of, known for being strong personalities themselves, correct?
Yes, they are. But they have to be. Right. If you think about it, this is a patient that you're basically taking and saying, okay, we're going to stop your heart and do all kinds of things to it, hope it doesn't fall apart, and then restart it. They have to be. They are in control of that room, and this isn't a room that has 2 people in it. You've got anesthesia, you've got perfusion, you've got circulating nurses, you have scrub techs, you have PAs. You have a whole lot of people that they're in charge of, that they have to run. It works well when you've got a team and we all communicate and everything works well. But if one part of that falls apart, it is not a good situation all around.
Right. Yeah. And the surgeon has to be responsible for all of that that's happening. What are the things that you really love about cardiothoracic surgery and that you think are the things that would draw people to this specialty?
Cardiothoracic surgery. So you've got cardiac, you've got vascular, you've got thoracic, you've got the combo of all of them. You have to love the acuity. You have to love, hey, there's a problem and I need to do something now. This is not like, oh, okay, there's a problem, but I'm going to wait till the surgeon gets out of the operating room in 5 hours and something. So there's a problem now. You got to take care of it, whether that's I have to run up to the operating room really quick and talk to the surgeon about it in the middle of the case and come back and take care of it, or I need to take care of it and then inform them later that that's what happened and what's going on and see what their opinion is. That's another thing. You have to have good communication skills. There are so many things. It's hard. Like you can tell, I love my job. I love my patients. I love my heart failure patients. I'm not the kind of person who's going to deal with your chronic problems. I know this about me. I am like here's your problem. Let's fix it. Move on. Great. If I never see you again, because that means we did our job.
Yeah.
And it's the constant turnover, the constant change. Like you have your base, then I'm okay to go my different directions with how things are working that day.
I assume that there must be a pretty high level of satisfaction from before the surgery to after.
There is. There honestly is. If you see somebody that comes in sick and you fix them and they're walking out on day 4 after surgery and they're just smiling and feeling great, you're just like, we did that. Yeah. That's another person that is going to have a longer life and a better life, and they've got time with their family, and it's wonderful to see that. And you get to see it every day. That's the great part about the job.
Yeah. I mean, there's not really many jobs, even in medicine. Yes, there are things that we do that are helping people in different specialties and things, and sometimes saving lives in other specialties. But I wouldn't think on a daily basis there's as much immediate reward and fulfillment knowing that you have saved or prolonged the life of another human being on a daily basis in your job.
Correct. Yes. Yeah. It's definitely, it's every day. It's wonderful.
But let's talk about the flip side, because not every case goes well. Not everyone is able to be saved. Can you talk a little bit about that, about the struggles in cardiothoracic surgery?
Yes. With the good comes the bad. Sometimes you can't do everything that you need to do or want to do just because of the situation that's going on. Sometimes you have bad outcomes. You have patients that have complications after surgery, and you're sitting there post-op day 10, 11, 12, and you're still having problems with this patient. It's hard. It is stressful, does take an emotional toll on you. You do bring that home sometimes, and that's hard, especially if you've got kids and a spouse. Sometimes you're just exhausted at the end of the day, but the family wants to see you and wants to, hug on you, and you're just like, okay, you try to hold on and give what you have left.
So besides the weight of dealing with, life and death, are there any other things about cardiothoracic surgery, some of the more maybe mundane things that are annoying in this specialty, whether it's paperwork or call or what have you, that people might not like or that they want to think about before they go into this specialty?
Paperwork and things like that, that's going to be across the board, the same across the board. You still have your notes, you still have your orders, you still have your discharge summaries, your HMPs. That is every single medicine subject. I would say it's probably call, weekends, and holidays are your biggest things. Because again, call, you can't predict, you can't leave town. You're kind of tied to the area and tied to the hospital. You might work all day, leave the hospital at 6:00 and get called back at 10 and be there all night operating, especially if you're in a transplant center or a place that takes, emergency dissections. And call is also a different beast because some people just take surgery call. Which is a little less stressful. Some people take call that you get from nurses all night from the floor or from outpatients overnight. And, you're trying to get some sleep. You got to go back to work the next day, but you're getting call at 11 and 12 and 3 and 5. And that's hard because you're not getting good sleep, but you do have to come back to work the next day. You still have the same stressful job that you're coming to. And then weekends and holidays, you've got kids and they're doing activities and you're like, I'm sorry, I have to be at work. I have to go in and take care of these patients and around. And that's another question that you do ask on when you're interviewing. Mm-hmm. This is a good point too. Like when you work weekends and when you work holidays, you have to say, do I have to be in hospital for the entire shift? Or is this, I come in, I round, I see the patients and I just take calls from home? Because that is a difference. Because if you can get in and see your patients and take care of them and still go out and spend time with your family, but still answer the calls, is different from, sorry, I'm spending 12 hours in the hospital on Saturday and I'm not going to see you and I'm going to miss everything that you're doing. There's a difference, but that's a good question to ask when you're in your interviews.
Yeah. And so we didn't really talk about schedule yet. Is a schedule normally a Monday through Friday, normal hours you would think like maybe 7 a.m. to 5 or 6 p.m.?
The majority of places are going to be your Monday through Friday, either 8-hour days or 10-hour days, just depends on your situation. The other option that you'll see usually out there are 12-hour shifts. And a lot of that depends on how much staff, if you're ICU only, if you're floor only, things like that.
So because people can have a dissecting aorta any day of the week. So if that happens on the weekends, then normally the team, the Monday through Friday team, they're all on call to come in if something happens on the weekend or holiday or whatever.
Yes. Yep.
Okay. So we talked about, going into this specialty, whether you have experience or not. Can you talk a little bit about that as far as what you think about like new grads coming out? Is this a specialty that you think they could or should even try to move into, or do you think that they should get experience doing something else, maybe another surgical specialty before they come to cardiothoracic surgery?
There's no reason you couldn't come in. You just have to be aware of what's ahead of you. You have to know that this is a massive learning curve. You just went through school and thought that was a massive learning curve. Try cardiac surgery. Yes, because you're learning the specialty. You have to learn how to read cath films. You have to learn how to read CT films. And that's just the care. Now you have to go and learn how to do EBAs. You have to learn how to first assist. You have to learn what the pump does. You have to learn what anesthesia is doing. It is a lot, and it will take a good 6 months just to be okay. And it takes a year to be good. It takes a lot longer to be really good. It's something that it's repetition and practice. You're going to basically kind of drown your first year. It's going to be hard, but you're not going to mind. And there's no reason that a brand new PA cannot handle that, because they can. I did. A lot of other people do. Don't think, I'll go do general surgery and then come in. They're not the same beast. It's two totally different things.
My experiences in medicine and a lot of people's experiences, unfortunately, haven't been great. Like you come out and they're like, boom, go do, and not a whole lot of training or developing or helping. Is this a specialty that the surgeons and the people working in know that they have to help develop PAs?
Most other specialties, if you go in a couple, like a month or two, you're able to stand on your feet and do the job. You can't in cardiac surgery. There's no way you're going to be a proficient vein harvester in 1 month's time. It's going to take you months and months to be able to do that. So you are going to have somebody standing there with you, helping you, giving you tidbits, training you. The same with when you're first assisting. You're going to have somebody standing right next to you. And I say it's a contact sport because there is no personal space in cardiac surgery. When you're in the operating room, you're closed in together. You're going to have somebody there guiding your hands, like moving your hands for you, like teaching you as you're going along. Like you will not be successful if you don't have that support. Same with the floor. You can't just say, hey, go take care of these patients. Like these patients are complex. They're sick. You're going to have somebody training there. But your question brings up another question that you have to ask during your interview. You have to say, what is your plan? Do you have a formal plan? Can I see the plan? Because some people say, yes, we have a plan. And you're like, okay, well, what is it? And they'll be like, it's this.
But you'll shadow for a week or two.
Yes, yeah. You need to be like, okay, when do we meet? When are we sitting down and discussing topics? When, especially for new grad, like when are we going to sit down and talk about coronary artery disease? When are we going to talk about, aortic valves? When are we going to talk about aneurysms? Like, you need all this stuff, and you have to ask these questions on interviews.
Do you have advice or thoughts for people that may want to transition specialties that are already working as a PA or an NP going into cardiothoracic surgery?
The best thing that you could do is shadow. Don't think just because I'm a PA, I don't need to shadow. If you're interested in it, because it is such a commitment to the training process and everything, go shadow. Like take a day off of work or a day that you're not working, find a team and just be like, hey, can I just come with you and you explain the job to me? And you'll get a really good idea of what it is. In the long run, it will save you, it will save them, and everybody will be happier.
Anything else besides shadowing that you would advise them to start doing? Any certifications to get? Any kind of courses to take? Anything that would help them be a good candidate and to hit the ground running?
ABA-CBS is out there, and that is a society that is specifically for our field. We're there to help education. We have products for you. We have our cardiac surgery orientation curriculum. We're out there. You can connect with us.
Is this only for PAs to join, or can NPs get the resources too?
NPs absolutely can. We have an associate category just for NPs, so they have access to everything also, and they can be part of our community.
So besides the association, are there any other resources, like particularly books or apps or anything specific that you use or would recommend people to use who want to work in this specialty?
Yeah, you can't work in cardiac surgery without hearing the name Bojar. That's basically the cardiac surgery Bible, and that's what you will hear a lot of people refer to, and a lot of people will be like, well, did you read this chapter in Bojar's? Did you do this? And that is the main thing out there that everybody will use.
So if you're interested in surgery, but you're not sure if cardiothoracic surgery is really the right specialty for you, then check out this playlist here. It's a collection of interviews with PAs working in various surgical specialties.